RPOC is one of the most common requests in gynae pathology, and one of the easiest to overcall. Because sometimes it's true retained gestational tissue, and sometimes it's just clot and decidua, or a high-risk mimic like uterine AVM, or a condition you must not miss like GTD. In the next 6 minutes, I'll give you a simple framework. Clinical to ultrasound to histology to reporting. Let's start with what RPOC actually means. Definition: set the map. RPOC means gestational tissue remaining in the uterus after miscarriage, termination, delivery, or curettage. Products can be chorionic villi, trophoblast, membranes, or fetal tissue, often fragmented. Clinically, it matters because it can drive bleeding, pain, fever, and delayed involution. But remember this rule: RPOC is a correlation diagnosis. No single clue is enough. So what should make you suspect it clinically? Clinical clues: fast. Suspect RPOC when bleeding doesn't settle, especially persistent bleeding, secondary postpartum hemorrhage, pelvic pain, or fever after a pregnancy event. The problem? These symptoms overlap with endometritis, subinvolution, and vascular lesions. So clinicians jump to ultrasound. Next, I'll show you how to read the ultrasound report like a pathologist. Useful, but not absolute. Ultrasound: what helps, what misleads. On ultrasound, typical RPOC cues are endometrial thickening or an echogenic intracavitary mass, sometimes with Doppler flow. The trap is big. Clot and decidua can look the same. A safer takeaway: ultrasound can support RPOC, especially a mass with internal flow plus symptoms, but tissue still decides. Before curettage, there's one mimic you must rule out. The dangerous mimic, AVM. If Doppler looks very vascular, always think RPOC versus uterine. AVM. AVM often shows serpiginous myometrial channels and high-flow signals, and curettage can cause severe bleeding. RPOC is more often endometrial/intracavitary tissue. With that safety point done, let's move to the specimen we actually receive, because grossing can make or break the diagnosis. Grossing: what to do. Most RPOC specimens are messy, fragmented tissue plus clot. Don't expect a neat placenta. Describe aggregate size and tissue types, then sample generously. Villi can be focal. If postpartum or adherent tissue is mentioned, look carefully and submit extra sections to assess for abnormal adherence. Now to the core question under the microscope: do we have chorionic villi or not? When it's not just RPOC, widen the differential if tissue seems unusually adherent, the history suggests risk factors, or bleeding persists despite treatment. Think placenta accreta spectrum in the right context, and think GTD if there's concerning trophoblast or abnormal HCG trends. This is where your report really matters. Next, I'll give you a clean reporting structure clinicians can act on safely. Histology anchor: villi. The most reliable confirmation of products of conception is chorionic villi. You may also see trophoblast, membranes, or fetal tissue, but villi are the anchor. And the key pitfall: decidua plus clot alone is not proof of RPOC. If you don't see villi, say so clearly. Next, let's make it even easier by adding timing. Postpartum tissue doesn't look like early loss. Timing changes the look after delivery. Retained tissue can be degenerate, necrotic, fibrin-rich. So villi may be subtle. In early pregnancy loss, villi can be tiny and easy to miss. Your discipline stays the same. Hunt for true villus architecture. Next, let's cover the common mimickers that create false positives and unnecessary procedures. Mimickers: you'll see 3 frequent mimickers. 1. Decidua can be abundant. 2. Arias, Stella reaction, atypical but benign. 3. Implantation site changes, trophoblast plus hemorrhage. Don't let these replace villi in your mind. Be descriptive, not assumptive. Now, when should you stop thinking simple RPOC and widen the differential? Reporting: clean plus safe. A strong report answers 1. Chorionic villi present? If yes, products of conception identified. 2. Inflammation. Mention endometritis if present. 3. Red flags. Note concern for accreta spectrum or GTD and recommend correlation. If villi are absent, say no chorionic villi identified. Now let's finish with a one-slide recap you can recall instantly. Recap plus CTA, final framework. RPOC is clinical plus ultrasound plus pathology, confirmed most reliably by chorionic villi. Avoid the big traps. Clot/decidua mimic RPOC, and AVM can mimic vascular RPOC. On histology, be disciplined and report clearly with red flags when needed. If this helped, like the video, subscribe for more high-yield sign-out frameworks, and next we'll cover postpartum curettage differentials step by step.